Good evening, sir. I am presenting the case of Miss M, 33-year-old lady, resident of Delhi, homemaker by occupation, graduate, para 3, live 3 mother, presented to our hospital on 15th of this month at 4:30 p.m. with complaints of reduced urinary output and breathlessness from 2 days post emergency cesarean section on 13th of this month. So I would like to present the history, the present obstetric history. So it was a pregnancy was confirmed with the UPT card test done at home on February of 2023. First trimester, it's a book case, had regular antenatal checkups, received folic acid supplementation. There was no history of hypertension, no history of excessive nausea, vomiting, and abdominal pain. She had felt the quickening movements at 20th weeks and had received 2 doses of TT. All her antenatal scans are uneventful, though she has reported hemoglobin of around 8 throughout the pregnancy despite adequate oral iron supplementation. So she had normal BP recordings throughout the first and second trimester. There was no history of fever, rash during first and second trimester. At around 36 weeks, 5 days, there was she has presented with reduced fetal movements, with spotting, with mild lower abdominal pain, with no history of foul smelling discharge, no history of fever, no history of headache, blurring of vision, excessive bleeding or seizures. So she was been advised by the gynecologist and emergency cesarean was done and has delivered term healthy baby with birth weight of 2.64 kilo. She post delivery she had maintained the good urinary output and she had been told that there are some blood loss for which she has received 1 unit of blood, and there was no history of fever or decreased urinary output immediately post delivery. On POD2 and post up day 2, for the reduced urinary output and breathlessness, she was initially managed with the IV fluids and the medicines to increase the urinary output, and ultrasound was done to see any retained products in the placenta. And as she remained anuric, she was initiated on hemodialysis on POD2 via temporary catheter insertion on 15th of this month at 7:10 a.m. and then she was referred to our hospital for further management. Coming to the course in the hospital, she presented with breathlessness and decreased urinary output, and she was started on IV antibiotics and oxygen supplementation. And as she remained anuric, she has been underwent 2 sessions of hemodialysis and as well as transfused with 1 unit of LDPRBC on 16th and 17th on consecutive days. There was no history of fever, rash, arthralgia, joint pains, no history of persistent headache, jaundice, no history of blurring of vision, seizures or excessive bleeding. Coming to the obstetric history, she has been married at the age of 20 years and the age of the husband at the marriage is 22 years. First pregnancy, it was a booked pregnancy. The first and second trimesters were uneventful. Coming to the third trimester at 37 weeks for abdominal pain and spotting and for reduced fetal movements, she underwent an emergency cesarean section and had delivered a healthy female baby with birth weight of around 2 kilos. And the couple has used copper T and condom as a barrier method for 4 years, and she has conceived her second pregnancy on 4 years later after the first pregnancy. The first and second trimesters being uneventful, and the third trimester she has delivered a normal vaginal. She has delivered a healthy baby with birth weight of 2.6 kilo. And after the 4 years of second pregnancy, this is her third pregnancy, which is the current one. Coming to the past medical history, there was no history of diabetes, hypertension, seizure disorder, bronchial asthma, or hyperthyroidism. Personal history, she belongs to a lower middle class according to the modified Kupusam classification. She is a graduate, married at the age of 20 years. She takes mixed diet. All her bowel, bladder and sleep habits were normal. Gynecological history, she attained menarche at the age of 12 years, had regular cycles, and there was no history of previous pregnancy losses or abortions. Summary. 33-year-old lady, para 3, live 3 mother with chronic anemia, had undergone emergency LSCS for reduced fetal movements and previous cesareans, presented with oliguria, fluid overload, 24 hours following the emergency cesarean section, requiring hemodialysis. However, there was no history of hypertension throughout the pregnancy, no history of fever, jaundice.
That you have said.
So she is currently anuric. She is currently anuric.
Normotensive, normodiabetic, no diabetic, para 3.
Yes, sir.
Go ahead.
She is currently anuric and sir, hemodialysis dependent.
How long after C-section?
Sir, after 24 hours, she started.
C-section में कितना time हो गया?
Sir,
C-section हो गया सर ये 15 को 13 को
13 शाम को
13th
13th evening को हुआ था सर. 14th evening she started
14th.
developing reduced urine output. 15th
I'm
early
not
morning.
convinced with your history that there was no decrease in urine output after the cesarean section and after one day all of a sudden cut down.
After one day, sir. After one day, it started gradually decreasing urine output, sir. From 16 hours, they have started noticing decreased urine output.
Whether they were not monitoring properly or that may be the reason, because
I'm not. That may be the
and
part.
there was one thing you haven't mentioned.
C-section था ना third वाला.
Third was C-section.
They must be monitoring urine.
Sir,
After the C-section, they must be monitoring hourly urine.
That what was that?
We can't get any information, sir.
You can't get it.
But she has been told that she has maintained a reasonably good urine output till 13-14 hours. After that, she has the reduced urine output.
And there is no intra cesarean hypotension. You
No, sir.
mentioned 1 unit
No.
of blood was given
No, sir.
because of there was
No history of hypotension.
When was this blood given? During C-section?
Sir,
Before, during, after?
Sir, at the end of near to the completion of the procedure, sir. I've been told.
So what do you think has happened to this lady? Can you give us a
so one more point. Sir, she had undergone emergency cesarean as well as the tubal ligation, sir. Ligation was also done. Tubal ligation.
Okay.
So
do you think it is common to do a tubal ligation in emergency cesarean?
No, sir.
So what is your etiological diagnosis? What is your...
Sir, my syndromic diagnosis will be pregnancy-related AKA, stage 3, sir. And because there was no
dialysis dependent will always be stage 3.
No hypertension, no blood loss, no fever.
You just give no. This is
sir, thrombotic. I would like to keep differential diagnosis. First differential diagnosis thrombotic microangiopathy, sir, because there was no other significant history of fever, blood loss, or hypotension or hypertension. And the second differential diagnosis, however, I can't completely rule out sepsis, sir. The third differential diagnosis being the acute fatty liver of pregnancy, sir. But I can't completely rule out acute fatty liver of pregnancy.
Normally, you expect acute fatty liver pregnancy coming to such catastrophic outcomes.
No, sir.
The other thing is, once you give a diagnosis, you must try to stay on that diagnosis, not list the causes of all the
Sir,
AKIs.
I would like to keep thrombotic microangiopathy as
well. Why do you keep that possibility?
Sir, insult has happened postpartum, sir. First thing, the thrombotic microangiopathy, sir, most common during
most
the
common.
Second and third trimester, and as well as the postpartum.
No, but postpartum AKI thrombotic microangiopathy is most common. That's what you are saying.
Thrombotic microangiopathy, like atypical
HUS. Are you
HUS.
understanding the flow of discussion? आगे आ जाओ सब लोग एक slot और आगे आ जाओ
यहाँ सामने बैठ जाओ
सब लोग आगे आ जाओ एक slot और आगे आ जाओ. See, it has to be interactive. It has to be interactive. Only then it is going to benefit you people.
Okay, you're saying it is. You want to say TTP or HUS?
Sir, atypical HUS.
Atypical HUS. Okay.
And
so atypical HUS. Now tell me the points in favor of HUS and points against of HUS.
Sir, as of now, from the history, I could make out that because of anemia and requiring transfusions, this is the only thing, and insult happened after the postmortem, requiring hemodialysis. These are the points favoring towards
what is the commonest cause of AKI peripartum which leads to AKN3 or stage of dialysis? What is the commonest cause?
Sepsis.
So, what else? Number 2?
Preeclampsia. Preeclampsia
is not going to cause AKI. It may predispose to AKI. In definition of preeclampsia, where is AKI mentioned? So a patient who has a chance of getting preeclampsia may get more proclivity for AKI.
AKI.
It's not AKI is not part of preeclampsia. Neither is AKI part of eclampsia.
So,
What are the other causes you know of postpartum, peripartum AKI?
so particularly for this case, any post-surgical cause, sir, any like because she has undergone tubal ligation, we thought of initially any
So-
accident ligation of ureter. I mean,
Accidental ureter तो दूसरा ureter क्यों बुरा मान जाएगा?
so bilateral tubal ligation.
Bilateral tubal ligation, bilateral binding of ureter. You have not heard of accidental hemorrhage?
Sir, there was no significant blood loss, sir.
So why blood transfusion was
Sir,
given?
only 1 unit was given, and there was no history of hypotension at all.
How do you know it? Surgeon will never tell you, anesthetist will never tell you, go into surgery one day, they will never tell you. Take this from me. No surgeon,
Is it
no
normal
anesthetist will tell you
after
that the patient has a
cesarean section
major
to give 1 unit
intra-op
blood?
No,
Never.
sir, not after cesarean, sir.
Not after cesarean. It's usually a bloodless surgery,
Yes, sir.
right? It's usually a bloodless surgery. So why? See, directly because the initial 2 pregnancies, if why atypical HUS will happen, there should be some complement defect and trigger is pregnancy.
Yes.
Why then it hasn't happened in first 2 pregnancies?
Those points away from the atypical HUS.
Better don't get nervous. First and foremost, whenever you say your first diagnosis, you have to be really sure what you are dealing with, right? So if you are saying HUS, TTP or MAHA, whatever you're trying to say, there must be some robust evidence for that. It is a catastrophic illness, you see. Surgery is done today and day after tomorrow she is on dialysis, correct?
Yes.
Yes.
48 hours. It's very unlikely for atypical HUS or TMA to go into that kind of a shutdown in 48 hours. What, in your feeling, is the most commonest cause of AKI here?
Sir, sepsis leading to septic ATM. Hemorrhage.
Accidental hemorrhage.
I've
Why
asked,
are you not thinking of accidental
sir,
hemorrhage?
I have asked so many times, but I didn't get any information even from the.
What information you will get in accidental hemorrhage? Anyone? Do you think accidental hemorrhage is a possibility here or not? What information you expect to say that this is accidental hemorrhage? Blood transfusion उसको मिला transfusion. In fact, correct me if I am wrong, HUS will not require transfusion so fast. HUS will not require transfusion so fast. And as my esteemed colleague has told you that, okay, tell us something about causes of atypical HUS.
Sir, it can be
Congenital,
Eh.
coming in 4th decade.
for this case, sir. It is
You have
due
tell
to
for this case,
complement mutation, sir. Complement factors
these
mutation.
mutations.
The complement factor F, H, and I, and MCP, as well as the autoantibodies to these complements. So these are the common things.
How will the autoantibody affect?
Sir, it won't make the C3 will be continuously in a activated state, sir. So there will be complement depletion. So it won't cause the C3 to get inactivated. So there at multiple levels these antibodies work. So depending upon the antibody, whether it is a C3 nephrotic factor, C5 nephrotic factor, antibodies to other C4. So it depends upon the.
So what is the commonest causes of here? Deficiency, which factors deficiency will cause HUS?
Factor F, H, and I, sir.
And Adams 13,
There is
that is
deficiency.
a very common cause. So how will you test this patient for HUS?
So
What
we'll
are the
test.
tests you are going to order?
Sir, we'll order complete hemogram, sir, with peripheral smear to look for any cystocytes and.
So when will you say cystocytes are present?
What abnormality you did a CBC, right?
Yes, sir.
What abnormality you will get in hemoglobin,
Normocytic.
TLC, platelets, and peripheral blood
So
stream.
normocytic normochromic anemia will be, sir, because of hemolysis.
Okay,
There will be thrombocytopenia, sir,
okay.
and Leukocytes, I'm not sure.
Huh?
Leukocytes, I'm not sure.
Leukocytes will be more or less. And what's going to happen? You have to tell the classical form first of HOS, na? Schistocytosis. So when will you call it schistocytosis? You are seeing a smear. कब बोलोगे schistocytosis are there?
Percentage you are asking?
Yes.
If I make your smear, 1 or 2 schistocytes may be there. That doesn't mean you have
After
schistocytosis.
how much you will say that
10.
this is Anji?
10%.
No,
Not,
no, no.
not.
Anybody will think of any other diagnosis? Cause? बैठ करो. Cortical? See, that is the pathogenesis. What is the causation of that? Accidental hemorrhage.
ठीक.
What is against accidental hemorrhage in this patient?
So the baby is completely
So
healthy.
why should
Doesn't
everything
matter.
happen to accidental hemorrhage in baby? The baby may remain alright, the baby may succumb to illness. Is it mandatory for accidental hemorrhage to kill the baby?
Not kill the babies, at least there should be some event for the baby.
Why? What is the pathogenesis of accidental hemorrhage?
Why she's having pain in abdomen at 37 weeks, lower abdominal pain, then spotting? What do you think? Was the
Sir.
placenta was high lying, low lying placenta? What was that?
Low lying.
Huh?
It must be low lying placenta.
Low lying placenta. So what is
Placenta,
coming?
sir, I would think of, if it is significant bleeding, I will think of abrupture placenta previa.
See,
That is why it is called hidden bleeding. In
Abruption.
accidental abruption, you may not have any bleeding per vaginum. Okay, you may not have any bleeding at all per vaginum. Where does all the blood go?
Concealed hemorrhage, sir, it will be.
So, why are you gunning? Why are you not considering accidental hemorrhage just because the blood loss you could not see? It will all be there. It will all be there.
No
Okay,
doubt.
tell me the cause of AKI peripartum. All the causes you know of AKI.
Coming to the starting from first trimester, sir. Pre-renal causes being the hyperemesis gravidarum and the septic abortions and viral infections, sir. Coming to the second trimester, most common being the pyelonephritis, UTI and pyelonephritis, and any renal canicularis disease, and in fact any glomerular nephritis can cause the AKA, and preeclampsia at the end of towards the end of second trimester. So preeclampsia. Coming to the around and TMA, particularly TMA during second and third trimester, and during the third trimester, sir, apart from all this, I would consider fat. Apart from all this, acute fatty liver pregnancy, and sir, any during the delivery, because of the bleeding, abruption or placenta previa, and post that, sir, postpartum will be considering atypical HOS and post-surgical related complications or atypical HOS. Sepsis.
First, second trimester में pre-renal causes हैं, then pyelonephritis, UTI, TTPA, and fatty liver of pregnancy.
No glomerular injury will bother you in pregnancy?
Sir, I have told that.
Which one?
Glomerular
Glomerular injury.
Actually,
मेरा फोन आ गया, sorry. क्या glomerular injury बताएं?
Lupus.
बताएं?
Lupus नहीं बोला.
Glomerular.
You should always be careful. Glomerular injuries and
Lupus
vasculitis. Lupus is a big scourge of pregnancy. Which collagen disease will remit in pregnancy? Lupus will aggravate, which will become less. Autoimmune illness will become less in pregnancy. Don't be nervous. This question is not going to harm your interest. Okay. चलो आगे पूछो.
Okay. Now, the thing is, the you are on a diagnosis of this is postpartum AKI, right? Your first possibility still is what, atypical HUS, or you want to know after this discussion you want to go with concealed hemorrhage leading to AT and AKI.
Sir, I want to conceal hemorrhage ATM.
First. Okay.
Okay.
Then you want to come on this atypical HUS. Okay. Any other diagnosis in your mind?
Sir, sepsis, sir.
So sepsis nobody can
Rule
ruled out, right? And
Unlikely.
and one thing is going in your mind is bilateral tubal ligation and bilateral ureteric ligation. It's
Sir.
very difficult now for nowadays. We are not seeing all these cases from.
And besides bilateral ureterial ligation, she will not be able to pass urine after 2 hours.
So that's why I have kept
And she
it.
passed urine for 24 hours.
I have kept
so
it.
That diagnosis is
Maybe.
totally untenable.
Okay.
जो उसका ब्लैडर में यूरिन होगा उतना ही तो पास करेगा ना bilateral ureterial ligation.
Okay. No, you tell me this patient, suppose, has a acute kidney injury in second, third trimester, and she required dialysis, right? How will you manage this patient?
Dialysis.
Suppose this patient is having AKI, needing dialysis in second or third trimester. How will you manage this patient?
I would like to keep the dialysis hours at least 24 hours, 20 to 24 hours per week, so at least 4 sessions, and I will target the burn less than 40. And before this, sir, I will give adequate counseling regarding the chances of miscarriage and preterms. And
I'm asking about dialysis. How will you counseling?
Sir, 20-24 hours the dialysis duration, sir, followed by keeping the burn at around
24 hours in a week, month, how much?
Week, sir.
Per week, say that.
20-24 hours per week and 4 sessions.
Targeting burn to around.
And
less than
targeting
35.
by
Burn less than 35.
And hemoglobin, maintaining of hemoglobin.
What will be the blood flow? What will be the dialysate flow?
So blood flow, I will be keeping at around 150, sir.
It should be less than 300 ml, and dialysate flow should be less than 500 ml.
As minimum, sir. I will try to keep it minimum.
Avoid intradialytic
hypotension.
And what is the average gain of weight in pregnancy?
So it's depending upon the BMS of less than 18 kilos, they can gain weight up to 15 kilos. So 12 to 15 kilos is the average weight gain.
So that thing you have to consider in your mind in second or third trimester, that 2 to 400 gram per week there will be a weight gain.
Yes, sir.
Right? There will be a weight gain. Right? That thing you have to be keep in mind.
Maintaining.
And what will be, you will keep the blood pressure?
Blood pressure, sir, will be keeping it around to maintain the systolic blood pressure 110 to 140 and the diastolic between 80 to 85, sir.
Whatsoever in literature is 120 to 140 and diastolic between 70 to 90. Okay. So this thing you will keep in mind. Now tell me, what happened to the kidney size in pregnancy?
So, the length will increase up to 1 to 1.5 centimeters, sir, due to the dilatation from the calyces onwards. Calyces ureters, there will be dilatation. So length will increase by 1 to 1.5 centimeters in size.
Okay. Why?
There will be dilatation, sir, because of this.
Dilatation will cause nephrosis, tract में. Why the kidney will go up?
There are multiple reasons. There is the renal hypertrophy, there is the
Glomerular
increase
hypertrophy.
in vascular volume, and there is increased capacity of the collecting system.
Yes.
All that. Because you can have a small kidney with dilated system, right? You can have hydronephrotic small kidney.
Yes.
You can have hydronephrotic big kidney. You can have hydronephrotic normal kidney. So They are two separate things, right?
Basically, glomerular hypertrophy.
Yeah. More blood stress is there.
So most of the changes they recovered back within
So 6 weeks.
6 weeks. Okay, what happened to the cardiac output, renal blood flow, GFR?
So, renal blood flow will increase to 80%, sir.
Okay.
50 to 80%. Cardiac output will also, sir. It peaks at 32 weeks, sir, and it's around. It will be increased up to around 50%, sir. And
Cardiac maximum 40%, yeah, that's good. कि renal blood flow 80% हो गया तो cardiac output भी 80% हो जाएगा. There's a
50%, 50%. And the GFR will also increase, sir. GFR will increase.
How much?
Sir, percent, sir, 40 to 50%.
25-30% GFR goes up, right? And what is the corollary of that increased GFR clinically? उसका clinically क्या उसका take away है?
So there will be washout of the natriuresis will happen, sir. There will be washout of the
Your BU and creatinine will fall down
sir.
significantly. So any pregnant woman in your practice, if she comes with a creatinine of 0.8, it is a big
Points.
ticket trouble. If
anything
she
more.
comes with a BUN of more than 15, it is big ticket trouble. Blood urea of more than 26, 27, it is big ticket trouble. Okay.
What is normal burn and creatinine in pregnancy, and how will you check the creatinine clearance in pregnancy?
Inulin, sir. No, inulin.
First,
Not
tell
that.
me burn and creatinine.
Sir, creatinine. Any value more than
What is the normal value
Point-
given?
0.6, sir. 0.6 to
0.43 plus minus 0.8, and about burn.
significant. We call it AK.
About burn, what is the value of burn?
Burn.
8.7 plus minus 1.3.
Maximum 12, 13, no more than
13.
Right? Now, how will you check the creatinine clearance?
Sir, not by the standard. Sir, MDRD and these equations won't work, sir. I will be using inulin.
So your answer should be there is
No specific.
recommendation about how to measure it, by which equation. The only thing decided by is the serum creatinine. So
Yes.
there is no
No
valid equation for pregnancy for measuring the GFR.
GFR. Yes.
क्वेश्चन पूछा जाता है एग्जाम में. ठीक है.
You know how to do inulin clearance? Then why are you mentioning it? It will be big ticket trouble, I'm telling you, because I know inulin clearance. What would be your creatinine clearance? If I just ask you, what would be your creatinine clearance? On the assumption that you are neurotensive, you do not have any kidney involvement. It's just like that. I mean, it's a guesstimate. Anybody's creatinine clearance here. On the assumption that there is no pre-existing disease, hypertension, diabetes, stone, etc. It's not a difficult question. It's written in the text. Very simple. 100 divided by your creatinine. Very simple. So the point I'm trying to make is, in the early part of creatinine, and a young person, what GFR do you expect a young person to have? 120, 125. And so the creatinine will be 0.7. You divide 100 by 0.7, you will come to that figure. So it's very simple. If you have no other existing comorbidity, your 100 divided by creatinine will be your creatinine clearance. And as you age, you subtract the age from the numerator and you get to your creatinine, right? Tell me a little bit of etiopathogenesis of accidental hemorrhage. It's a fascinating subject. All of you should be solid in that. In your lifetime, you will get at least 15-20 cases of pregnancy in AKI wherever you or wish to practice.
So there
And
will,
2 lives are involved.
first of all, there will be ineffective spiral remodeling, sir. And
They are accidental hemorrhage. की बात कर
Accidental
रहा हूँ मैं.
hemorrhage आपसे
I'm not asking you about
वो नहीं पूछ रहे.
pre-eclampsia.
Pre-eclampsia.
Don't pussyfoot with me. You want me to discuss pre-eclampsia? I'll go to pre-eclampsia. No? I'm asking you the etiopathogenesis of accidental hemorrhage, which you have to know. Pre-eclampsia चाहे एक दफे मत जानो. वो gynecologist का obstetrician का headache है. हमारा भी है, but more of them. etiopathogenesis of accidental hemorrhage. Anybody? See, it has to be an interactive session. I don't feel like that I should. You are all my younger colleagues. Anybody? तो पता था ना ये क्या है प्रेगनेंसी है. मैं तो अभी 10 मिनट 15 मिनट पहले ओपीडी खत्म करके सीधे आया हूँ. She was there with me. Anybody etiopathogenesis of accidental hemorrhage इतना मुश्किल सवाल है. ऐसे नहीं करते. बोलो कोई तो बोलो. हाँ etiopathogenesis इधर आओ. नहीं मेरे को तुम साइड में जरा. अब बोलो. हाँ बताओ. etiopathogenesis बोलो ना. प्रेगनेंसी. ये सॉरी. abruptio की. तो करना आपके लिखियों पे काम नहीं कर सकते. बड़ी प्रॉब्लम है. क्या भाई ये बताओ. बहुत बोरिंग है. कितना मुश्किल सवाल है. abruptio प्लेसेंटी कैसे है क्या करता है. इट्स अ टेरेबल डिजीज. अभी तक तुम लोगों ने देखा नहीं. प्रेगनेंसी के बाद जैसे ये डायलिसिस बता रहा है. हैव यू सीन और नॉट सीन? देखे हैं ना पेशेंट क्यों होते हैं.
Basically, the placenta that is attached to the endometrium layer, if there is detachment at certain section of the placenta, which could be due to the abnormal shape of the placenta or
whatever
any risk factors.
abnormal shape तो बेटा पहले ही आ जाए.
Yes.
9 महीने तक थोड़ी रुका रहेगा.
And whatever the risk factors are there, ultimately there might be direct involvement of the blood vessels also, where there can be rupture of the blood vessels, which can be retro site, that is a concealed type of abruptio placenta, like more of accidental one. Ultimately, once there is this amount of blood loss, which can ultimately lead to hypovolemia and prerenal AKI.
I leave you, and this is because I want all of you to remember this lesson in your life. You have patients coming with severe vomiting and diarrhea. They have ATN. बिना dialysis के most of them improve. At the most, you give them one dialysis, they stand and they go away. 2 dialysis, 3 dialysis, they recover. Right? You have surgical hemorrhages, they recover. What is the problem with the abruptio placentae? Why don't they recover? Why? Quite right. Answer is acute cortical necrosis, but the question is why? क्यों बुरा मान गई किडनी?
17
जोर से बोला कर. Absolutely correct.
DS.
Absolutely correct. In dehydration due to AG लिखने का नहीं है, ये दिल में बसाने का है. प्रेग्नेंट औरत से टकराओगे तो ये तुम्हारी नोटबुक तो घर में रह जाएगी. I'm very happy with you. Always remember that pregnancy is highly prothrombotic state. So now you have a situation where there is hypovolemia, blood flow is not going in, and it is getting thrombosed. So पूरी vessels में kidney के, and because kidney is fortunately a very vascular organ, 25% किडनी में जाती है ब्लड, सब ठस हो जाता है. Like this. Absolutely. This does not happen with dehydration. This does not happen with surgical hemorrhage. That is why this is so sinister. And that is why you have to act very rapidly. The kidneys will not recover. Okay? How will you diagnose acute cortical necrosis?
So CT.
सीधे पहले दिन में मिल जाएगा सीटी में.
कितने वीक्स में आता सीटी स्कैन?
ऐसे आंसर दोगे प्रॉब्लम हो जाएगी.
Sir, renal parameters, we will check the RFT.
Renal parameters,
Urine
output,
output, urine
recovery,
retin.
हर चीज देखोगे. सीटी स्कैन में कब आता बताओ डॉक्टर साहब का सवाल.
It takes weeks, sir. Weeks.
How much weeks यार?
वीक तो 52 भी होते हैं. 52 वीक्स भी तो वीक्स ही है.
हाँ भाई देवन कितने वीक्स?
1 month.
What is the
तेरा चेला है इससे तो आता है सब कुछ.
what are the signs?
गंगाराम का है ना तू. No wonder. हमें तो उन्होंने एडमिशन ही नहीं दिया गंगाराम में कभी.
Yes, sir. What are the signs?
बैठ जा यार बैठ.
Flank pain.
रेल रोड है ना. रिवर्स.
Callus.
So you can diagnose. You don't want to do the biopsies, of course. Then you can do not a plain CT scan, no?
Contrast.
Contrast CT scan. So then it will be after
4
4
weeks.
weeks, not
Early.
early. Right?
Clinically, flank pain hematuria.
Clinically, the best thing will be if you are not able to find the answer, biopsy is the
Biopsy.
answer.
Kidney biopsy. And what do you expect in kidney biopsy?
what is the histopathology of acute cortical necrosis? What you will get in the light microscopy?
necro.
हाँ जी,
Sir, ne- it will be completely necrotic.
दिखेगा
what
कैसे?
is appearance
उसमें लिख के
कैसा
आएगा नेक्रोटिक
पैथोलॉजिस्ट को पता लग जाएगा कैसे, कुछ तो appearance होगी ना स्पेसिफिक.
appearance. You must know the appearance of.
हाँ? What is
Gross.
ghost appearance?
नहीं ग्लोबुला एब्सेंट नहीं होंगे. Nuclei will not give. There will be disruption. There will be all over the place carriers. That the
You will not find anything. So the word is ghost appearance. These will be a simple question. They will ask you acute. What are the causes of acute cortical necrosis?
In the pregnancies.
I'm
Total.
asking general.
Total.
In general, sir,
Most
common
common
cause.
causes.
Bite.
Most common cause is bite.
So pregnancy related. Apart from the pregnancy related, sir.
What are the pregnancy related causes?
Any septic abortion, amniotic fluid embolism, DIC, sir. Particularly when there is DIC, sir, there will be.
What we were discussing first.
Sir, abruption.
Abruptio placenta is the
First common.
most common
किसी में
cause.
होगा cortical necrosis, किसी में cortical necrosis नहीं होगी. For that very reason.
Severe PIA or abruptio placenta.
Yes. Sir.
And it's the most common cause of acute cortical necrosis, contributing up to 25% of cases.
Yes.
Another cause of acute cortical necrosis?
Sir, bites, sir. Snake bites.
Snake bites. Or
Pancreatitis, sir. Yeah. Acute pancreatitis.
severe acute
Acute
pancreatitis
pancreatitis.
होगा ना, acute pancreatitis से कैसे?
Severe acute pancreatitis. Burns and acute. Even that
Or
was burns. And any poisonings? Not.
which poisoning? हाँ जी, बताओ जी.
Sir,
इधर
CCM.
कौन है थर्ड ईयर? ये पीछे बैठे हुए हैं मेरे तो, वो थर्ड ईयर है ना? आप थर्ड ईयर हो? अच्छा, सेकंड ईयर आप है ना. बताओ जी acute cortical necrosis के causes.
Pregnancy, snake bite, traumatic microinjury.
TMA will not cause cortical necrosis classically. It will have its own issues like that. You will have irreversible renal failure, but I don't think so. TMA will cause cortical necrosis. TMA is a disease of your capillaries and vessels. Here the big vessels are involved. The whole cortex is gone.
Sometimes APLA can cause acute cortical necrosis. So, acute cortical necrosis, if you say somewhere, they will call.
ब्रोमाइड में मिलता है क्या? थोड़ा
Think so.
कंफ्यूज चेक कर लेना. ब्रोमाइड में होता है क्या कुछ पता नहीं, but I'm not sure. Don't take it from me. You guys need to check it out.
Just what are the causes? They will ask you what is the light microscopic appearance. They will ask you how you diagnose. If you don't want to do a biopsy, how you diagnose. And this patient is absolutely anuric, right? Now, what is your line of management?
Sir, biopsy. If we do the biopsy, sir, we can know the reason for the anuria is still.
So what are the current parameters of this patient? What is hemoglobin? What is
Sir,
platelets?
hemoglobins are around 8.5 and 8.2. So these are the trend of hemoglobin. These are trend of hemoglobin and platelets are around.
Have you given the blood transfusion during dialysis?
Sir, we have given 2 units here, sir.
2 units more. Total 3 units she got,
Yes, sir.
right? 3 units she got after cesarean,
Yes, sir.
right? So after 3 units she picked up to 8.2. And after first blood transfusion, how much was the hemoglobin?
8, same, sir. Because they have done it 4-5 hours after the transfusion. So that was done in a different hospital. So we have been told it is 8.2.
Okay. Now what is total leukocyte count?
So total leukocyte counts are around 14,000.
14,000. Why it is 14,000?
One of them is I can't ignore sepsis, and there is stress because of
One reason is stress, another you cannot rule out underlying sepsis.
sepsis.
What is platelets?
The platelets counts when she came, it is they were around 50 to 60,000, sir, when she came.
Platelets were low.
Yes,
What is the reason of low platelets?
sir. Hemolysis.
You're saying hemolysis. Okay. Now comes to the what
Other
was
manifestations of hemolysis.
Sir, the peripheral smear is showing normocytic normochromic appearance, and as well as the bilirubin is indirect
no,
fraction.
what is the
There
cystocyte?
smear.
Cystocytes,
How much?
sir, they have documented as few cystocytes, sir.
Few cystocytes. Okay.
You have to say all electrocytosis, anicocytosis, all those things.
Sir,
They can be anything. Hemolysis की smear एकदम अलग होती है.
it's normocytic
Dimorphic
normochromic.
anemia की smear अलग होती है.
You have done
Hemolysis.
once peripheral blood smear, twice, thrice. How much time?
Once, sir, and we are repeating it because she has been transfused, sir, as soon as she came here. So just the moment she came, we have done the PS, sir. After that, we have
Okay.
not repeated it.
After that, you have is the cystocyte rising trend is important or a certain value is important? Suppose you may not get on the first sample and you are sending it repeat, you are strongly suspecting atypical HUS. Ideally, it should be more than 2% to say that it is atypical HUS. Okay, the rising trend is important.
Yes.
Suppose 1.5, we get okay, it is just 1.5%. Just wait, it may not be, but it is a rising trend. So
Yes.
you on the first reading, you should not be stake at that point only.
Yes. And the other parameters are low heptoglobulin, sir. Heptoglobulin levels are low.
Heptoglobin level.
Yes.
And what about LFT? What is the result?
Coming to the indirect fraction of
Most of
bilirubin,
the labs will not be able to do haptoglobins. But there are so many other things they will tell
Indirect
you.
fraction of
Hyperbilirubinemia,
reticulocyte counts are elevated, sir.
reticulocyte count,
Reticulocyte count.
LDH, all those things. You should say first.
Reticulocyte count is around 4%, sir,
Hmm.
and LDH is around 2,000, and
Okay.
1,500 in the morning. It is around 2,000 when she came.
Okay.
And other per bilirubin, sir, indirect fraction of bilirubin is around 4.
Okay.
Of total of around 6, indirect fraction is converting to 4, sir.
Okay. What about PTA, PT, INR?
Sir, PT is around 13, sir. APTT of around 28. 28,
And
29. INR 1.35, 1.36, sir.
Okay. What is D dimer, FDP?
Sir, D dimers. Sir, D dimers are around 2,000, sir. Exact value.
It is raised.
Yes, sir.
So,
Sir, initial one, the D dimer was around 4,208, and
it was raised.
raised. So
Okay.
D dimer is raised.
So
So
why
you-
is D dimer raised? What does it suggest you?
Sir, it can 3 things, sir. One is sepsis, sir. The other thing is coagulopathy.
DIC sepsis, na?
DIC sepsis.
So
So-
coagulopathy will be in accidental hemorrhage or HUS?
Accidental.
All other features can be in DIC, right?
Yes, sir.
Your indirect bilirubin can raise, your platelets can be low,
Low, sir.
right? Your TLC
Yes,
is
sir.
high. And what is your procal?
Procals are in our hospital 346, sir.
346. Okay. No. And what about your ultrasound?
Size of the kidney, sir, it's 9.5 on 10, and CMD is maintained with mild increase in the echogenicity. The liver and spleen are normal, sir, and there is mild collection in the pelvis, sir.
Okay. And high vaginal swab?
Sir, step negative is मतलब normal.
Non.
No. So no, tell
No.
me your diagnosis.
And how you will manage this patient? Rather, how you have managed it?
Tell me your diagnosis and no, after investigations, no, initially you have make a provisional diagnosis. Now all the investigations are available to you, 1, 2, 3.
Sir, this pregnancy related AKI stage 3 completely anuric, sir.
Then no need to say. Postpartum AKI, dialysis dependent.
Dependent.
Okay. Then
Sir, with collaborative evidence of volume overload and jaundice, I want to keep my different diagnosis as thrombotic microangiopathy and atypical HUS.
How will you manage her now?
Sir,
Does you know your first diagnosis is postpartum hemorrhage or
HUS,
Thrombotic.
thrombotic.
He stays with it. Okay, we respect it. How will you manage her now?
So we have we'll give treatment of disease proportion and treatment of the complications.
क्या
Sir,
किया? Tell me.
management of volume status, sir, by management of volume status according to the IVC.
You are wasting everybody's time.
Sir, dialysis,
You have already given.
sir, plasmapheresis, sir.
So you will start plasmapheresis straight away.
Procal is 364, right? TLC is 14,000.
Sir,
Your D dimer is raised. How will you explain this? Will you give plasmapheresis in sepsis in this patient?
Your diagnosis of HUS is not. Do you buy HUS? Anyone, all of you, do you buy HUS? If you are so sure of HUS, then you must biopsy that patient. Where is the diagnosis? Show me the cake. Where is the evidence of HUS? You haven't told us the schistocyte count on smear. You haven't told us about fragmented RBCs. All those
Cystocytes
things.
almost normal. So
No,
one thing you are telling low platelets. That can be in DIC.
yes, sir.
Your second thing is telling indirect hyperbilirubinemia. That could be in DIC. Your INR is deranged 1.3. Your procal is elevated. Your D dimer is increased. What about fibrinogen?
Sir, fibrinogen levels are 368, sir.
They are increased, decreased,
In decrease, sir.
decreased. So
Consume होगा ना? They consume.
consume.
Sir, what is favoring toward atypical HUS is one of the factor being very low C3, sir, which we expect to be
Very low
normal.
C3
Can
favors
be
HUS.
It can be in infection also here. Why cannot be in infection C3 could be low?
So
C.
if low C3 is there, then it supports HUS.
It favors HUS and not, sir. Because
So okay. C3 is low, so now you will have to put this because HUS is a potentially treatable condition. You will have to freeze this patient.
yes,
So you have given plasmapheresis to this
Yes.
patient. You have given it.
yes,
Tell me your plasmapheresis prescription.
sir. Today only I started, sir. It's we have given around.
You haven't started IV antibiotic in this patient.
Sir, IV antibiotics we have started, sir. IV antibiotics we have started good spectrum meropenem and I've started with IV antibiotics, sir. And we have started on the day one.
What is the status of the blood pressure of the patient at present?
Sir, till now it is 130/80, sir.
And initially she was on inotropic.
No, sir, never on inotropes. That is the points against the sepsis, sir. Even though procals are high,
So you have started plasmapheresis with what in mind? What is the target of doing plasmapheresis in this patient?
sir, we are suspecting any antibodies to the complements causing this.
So what tests have you sent and where have you sent them?
Sir, we have sent the complete complement mutation analysis, sir, and as well as the antibodies to the complements.
Okay, you have
Complement
sent it
sir,
prior to plasmapheresis.
before starting, sir. Yes.
Okay.
And so one more thing I would like to add, sir, that because we have done CT scans, sir, just to see the lungs, and so we have found that there is complete thrombosis in the IJV, and after the IJV and sir, complete thrombosis of the IJV and
CT
knee
scan
action.
say how you can look after the IJV from
CT venogram, sir. CT venogram of the and CT
So why
thorax.
was
CT
that done? Why did you do it?
Sir, there was no as such history, sir, but because she is having this volume overload, we just want to see the whether there is any effusion. So we just did a CT, sir.
Effusion के लिए CT scan करोगे सीधे.
सर एक्सरे किया था सर. एक्सरे में है effusion. It's around the right lower both of the vessel parts are completely opacified in the X-ray. So we have done the CT to.
And what did CT tell you?
उसके पहले अल्ट्रासाउंड भी कहते हैं सर. It's around 500 to 600 ml on both sides, sir. Effusion.
Bilateral fluid.
Pleural effusion is there.
No parenchymal lesion.
No, not significant. No
And
significant.
what did CT tell you?
Sir, CT thorax has revealed bilateral pleural effusion, sir, with basal atelectasis, and for the CT venogram of the neck showed thrombus in the right jugular vein, and
Why this was done? Because you are attempting IJV. What? Why it was
sir,
done?
it was done outside, sir. IJV we are not inserted because we are not.
IJV was done outside.
IJV was done here, sir. Femoral was done outside. IJV was done here.
Here
Yes,
on
sir.
right side.
Yes, sir. Right side.
Right side. No, it is the IJV is in C2,
Sir.
and then you did a CT venography.
We have kept EGV, sir, for the central line. Femoral line is still there, sir. The dialysis
Okay,
is
you have
ongoing.
done the
EGV for the central line IV
on
fluid
which
management.
side? Right, left,
Left side, sir.
left side. Why not right side? Because you are not able to negotiate.
Yes, sir.
Okay.
So that's why we have done CT, sir.
Is any previous prick was done on right side?
No, sir. We could not find it.
Okay. Then CT venography shows what?
So CT venography is showing thrombus in the with intraluminal hypodensities in the right internal jugular vein and brachiocephalic vein, sir.
What does it tell you? Where does it take you?
So we thought of APLA, sir, because there was
You thought of APLA.
In third pregnancy.
unlikely, sir, but thrombus is there. There
So-
was no accidental prick. There was no prick in the right side.
She got a dialysis outside.
So through the femoral, sir.
They might have tried there.
There was no prick.
Anesthetist may have tried for putting the central line when there is a. Have you checked that pricks?
किया था सर उसके बाद ही
Then why the venous thrombosis only? Oh, especially the IJV and leading up to is then you must have investigated the thrombosis anywhere else also.
sir because we are plan to investigate all this, sir, reason for
So what
thrombosis.
thrombotic profile you have seen and what you will send?
Sir, protein C, protein S, and homocysteine levels, and as well as the APLA profile, sir. But because of financial constraints,
प्लाज्मा आप कर रहे हो फाइनेंशियल
सर उसके बाद they can't afford,
अरे
sir.
यार प्लाज्मा तो हो गया
Max Sake's में
35,000 का प्लाज्मा होता है 35,000 कॉस्ट प्लाज्मा राइट सो
So that's an,
How will plasma help her? Tell me.
if there are any antibodies to the complement, sir, it will help in removal of the antibodies, thereby reducing this ongoing hemolysis, sir.
is postpartum HUS improved by plasmapheresis? Yeah, what are the case reports? What is the literature?
No,
Not.
no,
Right.
no, not that significant.
Not. Right? The postpartum HUS is unlikely to recover. The only treatment is eculizumab.
Eculizumab, sir.
Right?
Yeah.
So you are playing double-edged sword. See, I am very 340 procal. Say if it is 50, 60, 10, 12, it's okay. No, it's 340. It's too much. Your D dimer was 4,000 and it decreased to 2,000. Your FDP is low. So before considering each and everything, if you're considering the cost issue, do a biopsy first by transfusing the platelets and then
And prove that it is HUS or
Yes.
cortical necrosis and treat accordingly. If it was cortical necrosis, you have to
that
tell
should
her
be
to-
the right approach, right? If other parameters was negative, my approach will be similar as your approach. It's okay कि with platelets they are not going to improve without plasmapheresis, but here is a dual situation.
So what we have considered biopsy, sir, but we have requested the family and we have taken the consents also. So there is some problem with them. They don't
I think there is no problem. Okay, let us switch the roles. Supposing this patient came to you in 20th week of pregnancy
yes,
with some past history of some misdemeanor in earlier pregnancies, how would you manage it?
some past history of
Some problem like stillbirth or something. So, at 20th week she has come to you. The obstetrician needs your help. How will you take her forward?
so I would like to ask any history of miscarriages or abortions in that.
एक है stillbirth है बोला ना. अब इस pregnancy को लेके जाना है आगे. What are you going to do about this pregnancy?
Sir, I will send the complete APLA profile, sir. Lupus antiglobulin beta 2 glycoproteins and diluted racial vapor venom test, sir. DRBVT, and will be
Why will you send that? Just stillbirth? One stillbirth that you will
sir.
do
They
after?
will. I will toss any history of arterial venous thrombosis or any history of abortion, sir. If there are there, and there is presenting at 20th week in the second trimester, I would consider a plasma.
What are the causes of hypertension in pregnancy?
Sir, causes of hypertension in pregnancy.
How will you divide first? Pregnancy, what hypertension in pregnancy? One is gestational hypertension, one
Yes,
is
sir. One is pre-eclampsia syndrome, and the other is chronic hypertension. One is gestational hypertension, which sets before 20th weeks of gestation, sir, and it can be transient also, and it can be resolved immediately after the delivery, sir. And the coming to the pre-eclampsia syndrome, manifestation of hypertension setting after 20th week with or without proteinuria, or with multi-organ dysfunction, sir, and with uteroplacental dysfunction. And the other ATT being chronic hypertension, which sets after the 20th week, sir, and it can be of white coat, or it can be of essential hypertension, sir.
What else? One more condition. Mild CKD
Mild CKD.
will get aggravated. Mild CKD, some past pyelonephritis, some stone with some pyelonephritis, some earlier attack of FSGS or whatever, God knows what.
can pre-eclampsia lead to CKD? What are the studies and from which centers?
It is a risk factor for
So,
cardiovascular
so,
mortality. It seems that 50% of these patients later on develop cardiovascular disease. The risk of CKD is almost doubled in this patient.
In Swedish study, it is rare, but in Taiwan study, the risk is high. So read about this also, right? And what is the level of creatinine where you will say, okay, you can know the patient comes to you with serum creatinine of 1, 1.2, 1.5, 2, 2.5. How will you explain these patients that you will continue your pregnancy or you shouldn't not continue your pregnancy?
so just based on the creatinine, the management doesn't differ, sir. If the based on the gestation, if the presentation is at before 37 weeks, I would the patient is in pre-eclampsia.
I'm just saying the patient is having chronic kidney disease, right?
Yes, sir.
With the
Chronic
serum
kidney
creat-
disease, sir.
with
When the
serum
creatinine is
creatinine of
less than
1.5, right? With the serum creatinine of 2, with
Yes,
the serum creatinine
got
of
it.
2.5.
Sir,
How your counseling will differ?
sir, when the serum creatinine is less than 1.5, the chances of live birth will be high, sir, around and 90% the chances are live birth, and the preterms will be around 85%. When the creatinine is in between 1.5 to 2.5, it will decrease to 80%. That live births will be to 85%.
See, 1.5 to 2 is the gray zone. Above 2, the chances of stillbirth,
Birth
IUGR,
will increase.
maternal and fetal
Yeah.
outcomes will be worse.
Worsen.
So, which glomerulonephritis they will worsen in pregnancy? The proliferative glomerulonephritis, they will worsen in pregnancy, and another is the FSGS. So they will progress rapidly.
Yes.
Okay, so see around the gynecologist will send you. Okay, this patient is having creatinine of 1.5. She want to continue the pregnancy. You will say okay. Between 2 to 2.5, you will say this is a gray zone. Above 2.5, you will say okay, you should not continue. You may progress to the even ESRD, and your fetal outcome may not be good. These are the practical things you have to keep in your mind.
What will be the indications of kidney biopsy in pregnancy?
Sir, less than 24 weeks, if there is de novo proteinuria with impairment in the renal function and with active segments, so I'll be doing the kidney biopsy, sir. And if gestation is less than 32 weeks and we are planning to go for any immunosuppressive therapy, then we'll be considering the biopsy, sir. In cases of with AKI with active urinary sediments, and in cases of newly diagnosed lupus or lupus which is getting deteriorated.
Okay, you did a biopsy and you got IgA. How will you treat her now? Pregnancy is going on, 29 weeks. You have to do a biopsy for all those reasons, active sediments, proteinuria, and all those things. And it is IgA at 30% presents, 20% present. Name your present, not more than 50. But how will you treat her now? Tell me all 5-6 points. In points. Nutrition, hypertension, salt, and then immunosuppression.
So nutrition, I will be giving protein intake of around
How much?
0.7 to
Why 0.7?
One-
Where did you read 0.7 in pregnancy?
What is,
till 1
what
gram.
is the protein intake for pregnancy?
It
It
is
is
like
low.
No, it's high, sir.
it is like a hard labor, manual labor. You see, pregnancy requires a lot of
1
calories
gram.
and proteins.
Value of that.
You have to give 1.1, 1.2 grams.
Yes, 1 point.
Okay. Salt.
Low salt dates are because
Why low salt?
pregnancy state of anyway is sodium retention, sir. So I just want to keep in the low salt date. And sir, BP.
How much salt will you give her?
Sir,
We give advice for salt in terms of salt
Nah.
or in terms of sodium?
sodium, sir. Sodium.
So how much sodium will you give?
2 gram.
2 grams sodium.
Salt.
So 2 grams sodium or 2 grams salt? Are they same or are they different?
2 gram salt, sir, and 9 millimoles.
मिलीमोल कैसे बने 2 ग्राम सॉल्ट से 9
तो
मिलीमोल
बच गया अब तो
अब ये नजरिया आ गई है मुंडों के चक्कर में ये तो हमारा प्लेग्राउंड है फंस गया है यहाँ पे Okay, now tell me how many 2 grams salt will give you sodium? How many sodium
how
or
will you
grams?
calculate from gram to milliequivalent
बता
conversion
दो
of
भाई. Anybody?
हाँ जी
Anybody?
बताओ जी gram to milliequivalent conversion
लगा यार तो गंगाराम में राणा साहब ने लिया नहीं हमें
नहीं नहीं
इसको ले लिया तो बता दे लड़का स्मार्ट है
2 grams or 2000 milligrams. So 23 is the sodium molecular weight.
मॉलिक्यूलर वेट एटॉमिक वेट गलत बात मत बोला करो एग्जामिनर को गलत बात फौरन कैच करेगा सोडियम क्लोराइड मॉलिक्यूलर वेट सोडियम एटॉमिक वेट फंडे क्लियर रखो अपने लाइफ विल रिमेन सिंपल तो
Divide 2000 by 23. That gives us the
कितना हुआ 34-35 आ जाएगा 34-35 आ जाएगा दिमाग पे जोर मत लगा 1000 पे 17 मिलीग्राम सोडियम जाता है 1000 मिलीग्राम 5 ग्राम में 85 सोडियम जाता है
तो 2 ग्राम में कितना
34 40 मिलीग्राम कार्डियोलॉजिस्ट देते हैं 2.4 ऐसे 34 मिलीग्राम देते हैं ठीक है दैट इज हाउ यू हैव टू टेल
तो कितने milliequivalent देगा pregnancy
अच्छा आगे इम्यूनोसप्रेशन कैसे दोगे इसको चलो आईजी आया प्रोलिफरेटिव है 50% से क्या दोगे ये तो सेट है बिल्कुल महा पे महा के अलावा इसे बात करनी नहीं है कुछ तुम महा पूछ ले इससे टीएमए सोच के आया ही डज नॉट वांट टू एंटरटेन एनी डायग्नोसिस एक्सेप्ट एचयूएस
I
हाउ विल
any immunosuppression you can give which if you
ये
want
तो
to give
सिंपल
Sir,
से सवाल है
Uh,
एंटी हाइपरटेंसिव कौन से देने हैं कौन से नहीं
antihypertensive which antihypertensive you will give in the pregnancy
antihypertensive.
Yeah.
Sir, levodopa, sir, I will be given.
okay
और
Hydralgin for the emergency, sir, and for
हाइड्रोलिसिस उससे पहले और कुछ नहीं सोचोगे ड्रग्स
calcium
कॉजिंग
channel
आरपीजी
blocker.
हाँ?
Calcium channel blockers.
एम्ब्रोडेपिन दो
Methyl dopa.
लेवोडोल
So,
दो
depending
और
upon the emergency or urgency. Emergency methyl
टाइम
dopa.
टेस्टेड मिथाइल डोपा अब मिलती नहीं मिल जाए तो दे दो
और क्या
हाइड्रोलिसिन आई
देते
डोंट थिंक सो द गुड ड्रग
हो डेपिन देते हो
Methyl. Levodopa, hydrogen, sir.
और कौन सी ड्रग देते हो
Alpha blocker.
हैं?
Alpha blocker.
अल्फा ब्लॉकर you can give level 1 indication नहीं है
These are the 3 common drugs, sir.
ठीक है है.
we'll buy that. Diuretics के बारे में क्या status है pregnancy में?
So it will cause a volume contraction, so they are generally avoided.
Earlier when I was a DN student, there was a big no-no for diuretics, but now they said that in many situations, under guidance you can give diuretics because
Why
they
you
get
want to
very-
avoid diuretics in pregnancy?
So it will decrease the uteroplacental flow and cause the fetal complication.
Why is the BP less in pregnancy? Their volume is too much?
There will be sir, systemic vasodilatation.
Why?
Sir, because the vasculature is unresponsive to the vasopressor agent, sir, and there will be
Quite right. So pregnancy is a paradox. You have lot of blood volume there. The blood volume is up by 45-50%. And we know blood pressure is equal to cardiac output into total peripheral resistance. So if the cardiac output is high, you would expect pregnancy to be hypertensive, but it is not. Because the total peripheral resistance is totally down. Quite right. So much so that if you give them angiotensin, which is a very powerful vasoconstrictor, nothing will happen. BPL will not rise by 10. You give them angiotensin drip, totally resistant.
Now the question is which no, I will ask
Immunosuppression.
in different way. Which immunosuppression you can give in pregnancy?
cyclosporin, sir.
Huh?
Cyclosporin and
Or
और
tacrolimus.
पहले prednisolone नहीं
So,
करोगे?
steroids से देते हैं. Steroids,
CNI,
steroid,
steroid,
steroids.
CNI, or
azothioprine, sir.
okay,
Quite.
okay. Can you
Tag
give
को कैसे
MMF?
manage करोगे?
Sir, no, sir, no, sir.
What are the side effects of MMF if you give?
Sir, fetotoxic, sir. One,
What it cause?
atresia,
Which atresia?
ear,
Esophageal
Atresia,
atresia, cleft lip,
cleft lip,
cleft
lip
palate,
palate,
ASD.
yes.
1, 2, 3 side effects you should know,
Sir, yes.
right? Will you give rituximab in pregnancy? What is the data?
That. So I won't be giving
When if you have given the rituximab, when you should plan the pregnancy?
6 months at least.
At least 6 months. But in some patients, they have given in the
They have
pregnancy.
given it.
In the pregnancy.
There is no absolute contraindication.
It's a relative.
You can give.
Okay.
Tacrolimus दोगे क्या ध्यान रखोगे? What will be?
Sir, I won't be monitoring the trough levels. I won't be changing the TAC levels, TAC doses, sir, depending on the trough levels, because the dynamics are
Normally, you will expect much higher doses of CNI in pregnancy, and you should do the monitoring more often
more frequent.
than non-pregnant person.
And how much weeks prior to pregnancy you should stop MM?
6
6 weeks, not 6
6
months.
weeks, sir.
Okay.
Before conception, before planning a pregnancy.
इतने ही questions pregnancy में पूछे जाएंगे बस. But you should be able to reach a diagnosis, right? And
Anybody, any doubt, question, comment before we close, है ना?
yeah. So how many are in favor of HUS?
You should be honest.
Honest. Just raise
nobody
your
knows.
hand.
Nobody
Just
knows.
raise your hand.
You should be honest because you will
This-
face all.
No, not with us. I'm saying if you are in favor, just raise your hand. So we see whatsoever is ultimately with biopsy come and you have started the plasmapheresis, there could be mixing of double picture, right? If sepsis bhi ho gaya, ye bhi ho gaya. But with your when you have done the investigations, then even the examiner will go more in favor of
Sir, there was
BIC sepsis.
even in our hospital problem is that, sir, sepsis we have thought, sir, but there was not even a one episode of hypotension.
Said that doesn't need it. In we have, you must know, you will see in your clinical practice also.
नहीं,
It doesn't
so
mean-
basically what you are trying to say is कि hypertension नहीं हुआ तो DIC को
ETS.
Sepsis.
abruptio नहीं हो सकता.
No, saying
Yes.
That is what
88.
you are saying.
He is saying sepsis नहीं हो सकता.
Sepsis is still the possibility, sir, but more than that, I'm
DIC वो नहीं हो सकता.
Abruptio नहीं
because
no, sir, I'm not saying abruption है सकता है. I'm still
what was the blood pressure you measured first time you came?
sir 130/80.
So that is hypertension for her. I would have expected 100/60 immediately after delivery.
So they have given the
Please-
fluid
Please
resuscitation, sir.
understand. Please understand
Yes.
the wicket you are standing. You get the point.
See, pregnancy will be
Immediately
a
pregnancy,
trigger for
immediately
HUS. You got my
96,
point.
Yes.
Why it happened only in third pregnancy? My question. It should happen in first, second, but it happened only in third. What happened in third pregnancy that it become a trigger?
Some blood loss.
Is it? It's like that. It can happen at any blood loss as a trigger. Something should be there. Na? Triggering factor should be there. Na?
Okay, tell me, when will you do plasma exchange? When will you do pheresis?
Sir, plasma pheresis to just
And what is the difference between the two?
so plasma pheresis will be doing this with the plasma infusion and plasma pheresis.
The important thing is when you are making a diagnosis, at least on that diagnosis, you should be able to stand like the best batsman in the world.
So plasma pheresis will remove the antibodies also. Plasma infusion just replenishes
Exchange.
the
Plasma exchange.
so plasma exchange will remove the antibodies, but plasma infusion just it replenishes the deficient factors. Sir.
And pheresis, you should be able to write a prescription. Can anybody give me a prescription for this 60 kg lady for her first plasma?
How you will calculate the
So
plasma
0.0
exchange?
0.07 into body weight, 6 into body
Sorry.
into symptomatic.
If we have to take, we can 30 to 40 ml per kg.
That's a good answer. That's a good acceptable.
So,
That's a good answer.
in Broadway, we will be giving depending upon the hematocrit 30 to 40 ml, 45 ml per kg, but using the formula as he said, sir, 0.06 into body weight into 1 minus symptom.
अच्छा किया, good.